Hi, everyone, and welcome to our Ask the Expert S&P Edition webinar series. We're so glad you could join us today. Whether you're tuning in as a parent or patient or someone supporting a loved one with food allergies, you're in the right place. I'm Dr. Sharon Chinthrajah, and today I'm joined by Dr. Edwin Kim, an amazing expert in the food allergy field. He is the director of the University of North Carolina Food Allergy Initiative and the division chief of allergy and immunology. He's an amazing researcher, doctor, and a very good friend. Thank you so much, Edwin, for joining us today.
I'm super excited to be here.
Food allergy has been around for a long time. We're hearing more and more about it in the last decade. And in the last 2 years, therapies and research have really come to light on how food allergy families can manage their food allergies. Let's talk a little bit more about what therapeutics look promising in your mind for our food allergy families.
Yeah, so really, again, right now, exactly as you said, I think the idea that there are options is so exciting. I mean, for far too long, really, food allergy practice was identifying what someone might be allergic to. So, oh goodness, it looks like you're allergic to peanut or milk or egg. And then, unfortunately, just kind of giving some guidance on how you can best avoid it and be ready for the worst. And really, it's just sort of an unnatural feeling for any parent that's out there to just kind of have to wait for something bad to happen as opposed to actually proactively being able to do something about it. And so fast forward to today, and like you said, in the last couple of years, I think just the emergence of different types of immunotherapy, the oral, the sublingual, and even the epicutaneous, that peanut patch that's being developed now. And then, of course, the biologics, this omalizumab, anti-IgE biologic medicine that can potentially treat multiple food allergies all at the same time. I think really, again, the advances that have gotten us to this place have really transformed what food allergy treatment and even just that conversation I have with my patients in clinics looks like now.
Yeah, I totally agree. And I think compared to, 10 or 12 years when I entered this field and really started doing research in food allergy, we've seen such amazing progress. What drew you to the allergy field?
Yeah, I mean, I think just even backing up before food allergy, just even allergy and immunology, I think really this is maybe going back too far, but just I first got drawn to the immune system, just the idea that, our bodies have this system that is there to basically protect us against anything that could possibly be out there, was just fascinating to me. And so it made me really interested in understanding more about how the immune system could be so specific and so great. But then as I learned more, then I realized, wait, it's not that great. And it can make mistakes. And that's where you start to see things like allergy or autoimmune diseases, situations where immune system isn't able to sort of control itself the right way and maybe is doing the wrong thing. And so that's where even more I really want to understand sort of how does our immune system work. Then eventually, actually during my training over at Duke, I was fortunate to work with Dr. Wesley Burks, one of the leaders for many years when it comes to food allergy and food allergy research. And that's where I started to learn a little bit about the work that he had been doing in oral immunotherapy and in peanut allergy. And that really drew me in, just understanding like food is everywhere. I mean, everything we do in our lives seems to revolve around food. And so trying to understand like how could something that should be so basic to us actually do harm. And so trying to understand like why is this happening in the first place? And now really what can we do about it so that we can try to sort of protect folks and allow them to enjoy food for what it should be.
It is really amazing how our immune system can be wrong
Yes.
about what's dangerous and what's not. And our field, I feel like, is so interesting in the ability to kind of really find ways and understand the mechanisms where our immune system goes wrong. And I feel like the immune system and allergy immunology really affects kind of every organ system. When we talk about allergic reactions, it can manifest in any organ system, right? What do you tell your patients, on how to recognize an allergic reaction to foods?
Yeah. So there too, depending on the patient, but a lot of folks that I talk to are familiar with, say, bee sting allergy. If you get stung by a bee and then you have that anaphylactic, scary, life threatening reaction. So oftentimes I might use that as an example Because like you said, underlying all of this at the immune system level, it's the same type of process. Allergic reactions and anaphylaxis uses that IgE antibody. And so trying to find examples that might fit for that family to help them understand. If it's not the bee sting allergies, some folks may be familiar with, say, penicillin allergy.
Mhm.
That's another situation that could cause anaphylaxis. Or even other allergic diseases, thinking about, say, seasonal allergies or even asthma, but trying to find some way that folks can connect and understand how the immune system can be involved. But then coming back to ultimately, like, that's why we need to understand more because we know all these diseases are tied together. And if we can kind of understand why this is happening in the first place and why there's so much more of all the allergic diseases and in particular food allergy, that may sort of give us a hint to try to figure out how we can actually get rid of this thing, how to actually cure food allergy.
Yes. I mean, I think, at least in my clinic, our food allergy patients, 2/3 of them have other allergic conditions like asthma or seasonal allergies. And, we see it at any age, from babies into adulthood. People can have the trifecta of food allergies, asthma, eczema, or atopic dermatitis. And to your point, I think we're really interested in trying to figure out how can we stop allergic inflammation and this kind of incorrect training of the immune system to react to things in our environment, whether it's foods, pollens in the air, bee stings, though I can understand why that might be considered foreign and dangerous. But yes, I mean, I think this is what's really important in recognizing signs of anaphylaxis. So, for food allergy patients, or for people who love a food allergy patient or care for a food allergy patient, what do you tell them to try and discern if what they're seeing in front of them is a reaction to something that a food allergy patient has eaten? What are some of the education points and tips and tricks?
Yeah, so I think there's probably three main areas that I really try to focus on when I'm talking to these two of my families and to my patients. And number one is going to be the actual food itself, because although we know that our immune systems can become allergic to pretty much anything that's out there, we know that that's not actually the case. That typically doesn't happen, and that there are these 9 food groups that are much, much, much more common or likely to be a food allergy than others: the milk, egg, wheat, soy, peanuts, tree nuts, fish, shellfish, and now sesame. And so first starting there, if that patient has eaten one of those type of foods, automatically in our minds, the chances of that being an allergic reaction are far, far, far higher as opposed to some other food like say kumquat or something like that. I mean, could you become allergic? Sure. But the chances of that are so much less. So starting with really kind of talking a lot about the most common foods. The next thing I try to talk about is the timing. So we know when it comes to food allergic reactions, almost always they're going to happen very shortly after eating that. So if someone has just had a meal and then symptoms are popping up in the next, say, 10 to 15 minutes, absolutely could be a food allergic reaction, could fit. If they're talking about symptoms that are popping up the next day or a week later, maybe it's related to the food, but it's not going to be a food allergy. And so thinking about sort of a different kind of process when trying to figure that one out. And then finally, I get down to the symptoms themselves. And I go to the symptoms third because that's probably the most confusing. So again, starting with the food, then the timing, and then the actual symptoms. And so, most folks know what hives might be or rashes, but if they don't, just sharing that they're going to be those itchy bumps similar to mosquito bites. So really, again, if you're eating that, if you're having one of these likely food allergy foods, within 10 to 15 minutes, starting to get these itchy bumps all over the place, that could be a sign that it's a food allergic reaction. We know we're eating the food into our stomach, into our GI tract. So stomach ache and even vomiting absolutely could be symptoms that come with this as well. And then some of the stuff that is going to be naturally more scary for us, anything that might affect breathing. So if you're having sort of your chest is tight, you're having trouble getting air in, you're coughing, you're wheezing, any of those also can come into play as well. There are other symptoms, of course. There's swelling. You can have, hand swelling, eye swelling, lip swelling, some of these things. Of course, we're always nervous about your throat swelling as well. But usually I start kind of talking about the most common symptoms. So again, it's going to be the rashes, it's going to be the stomach ache and potential vomiting. And then we get into some of the other type symptoms that could happen as well.
And really, it can manifest with symptoms in any organ system. And that's because we've got immune cells circulating throughout our body. Can we switch gears and talk a little bit about advances in management? In a previous Ask the Expert S&P edition webinar series, we've reviewed Neffy versus Epi. Can you tell us a little bit about, what you're using or advising patients on how to manage allergic reactions?
Yeah, I mean, of course, sort of I built my career around trying to develop new treatments for food allergy for desensitizing. But I think maybe just as big, if not a bigger breakthrough, is this non-injectable epinephrine. And the reason I kind of say that is I feel like every allergist I've talked to out there can remember a story of someone having an allergic reaction that probably coulda, shoulda used epinephrine. And they managed and got through it. But really, again, it was a difficult situation. And if they had just used their epinephrine, they probably would have gotten better a lot faster, maybe with a lot less sort of discomfort. And so I've kind of wondered, like, why? Like, why didn't they, if they're having sort of difficulty getting in the air, if they're coughing, if they're having a rash, why in the world wouldn't they have used epinephrine? And one of the number one things that comes up over and over again is it's scary.
It is
It's
scary.
scary, the idea
You're right.
that, I'm giving myself an injection. And even the words that families use, like, don't make me give you a shot, or I might have to stab you, or you can tell in the words that they use that this is a very sort of frightening kind of situation. And so my hope is that having a non-injectable version of epinephrine takes some of that sort of fear away. Will it take it all away? No. But if folks are less concerned about the idea that I might have to actually give an injection and more likely to use the epinephrine when necessary, I mean, that in itself is going to keep so many of our families safe. So I really am hopeful and expecting that this is going to be just as big a breakthrough as a lot of the treatments we've come up with for food allergy as well.
Thank you. I couldn't agree more. And I think one is the fear of using it. And then the second is the fear of using it incorrectly. Like, am
Yes.
I going to cause harm if I use epinephrine for a sniffle?
Hmm.
Right. And in most cases, what do we think?
Yeah, I mean, we just, I always tell my patients we know epinephrine is safe. We know epinephrine is safe. It treats the symptoms of allergic reactions. When in doubt, use it. It's always been my advice from day one. When in doubt, use it. But then again, if I put myself in the shoes of a parent, and actually, as it turns out, my kids all have a food allergy. So we've been in this situation, the idea that, okay, I don't know what this is. Is this a food allergic reaction? Is it, do they really have a stomach ache? Is this really a rash? Should I use epinephrine? It's not easy, and then especially again, if you add to it the idea that, oh my goodness, I might be giving an injection. But if it's a nose spray of a medicine that we know is safe, my hope is that there again, it will sort of remove that barrier and folks will be more likely to use it and use it early to prevent symptoms from becoming any worse.
Yeah, I think that is so key. Use it early, whatever form you have, whether it's the nasal spray or the injection. And I think my experience, at least, has been when we use it early in our clinics, patients feel relieved. And I think that we really do stop the build of the allergic reaction from progressing to worsening symptoms, concerning symptoms like respiratory symptoms, but even like worsening rash or stomach ache or vomiting. I do think that if we use it early, we really do stop the progression of the allergic reaction.
I totally agree. I mean, all the symptoms, even if they're not technically life threatening, they are
Yes.
absolutely uncomfortable. And again, if we have a way to turn that off and just help our patients to get better faster, oh, I mean, my goodness, it's on us to do it.
Yeah. And I think the other point that I just want to highlight that you said so well is that it is hard to discern what is an allergic reaction versus like something else going on. And I think, what you said is when you're in doubt, epinephrine is safe and can be used. And so I think these are tough things as a parent or as a caregiver to be able to manage. But I'm so glad that we have some new advancements in the treating. I want to switch gears and talk a little bit about therapeutics for our food allergy families. You've been involved in so much of the research for oral immunotherapy, sublingual immunotherapy, omalizumab. I'd love to hear your thoughts about how you think about these different treatment options and what you're excited about and how long these conversations are now that we have multiple choices for our families.
Yeah, I mean, I think I'll start with your question somewhat backwards here of, I think what am I most excited about? And I think it's that there's choices. Like you mentioned up front, we've been very fortunate to have been part of research studies across all these different treatments, whether it's the oral immunotherapy, the sublingual, the epicutaneous, the biologics, even some of these newer things that are out there. And really, I think the idea that patients can potentially have choices of what might fit for their sort of the goals that they're looking for, as well as what they're actually able to do realistically, sort of in their actual household or that sort of stage of life. And I think that's probably what I'm most excited about. And so, of course, starting with the oral immunotherapy, the conversation I have there is we've been studying this for, my goodness, at this point, what, 15 to 20 years.
Yeah.
So it's like by far the best studied treatment out there for food allergy, and we know it works. When we can get someone built up on an oral treatment, whether it's for milk or egg or peanut, we know we can get kids and adults with allergy as well to high levels of tolerating that food. Can we get them to the point of curing them? And that's the part that we're probably not quite there yet. We get some patients who can get a lasting benefit, something we're calling remission, but we're not quite sure that is actually getting to the cure. But we do know that it can get a really strong sort of protective benefit for a lot of these folks. But we also have learned over that same amount of time that, man, it's hard to do. Again, the actual doing of it, the actual preparing the food and eating the food and the office visits that come with it. And then it is a form of exposure therapy. We're giving folks what they're allergic to. We're doing it in a sort of program controlled way to keep it safe. But anytime you're giving someone what you're allergic to, there is a chance of allergic reaction. So it does come with risk as well. And so I think that's really sort of called for the folks who can't do the oral immunotherapy and can't get to that benefit. What are alternative options? And that's kind of where the work we've done in sublingual, we're really excited about as well. And so, again, the idea of a similar exposure therapy, but rather than eating large amounts of the food, small amounts of the food protein held under the tongue to access the immune system there. And of course, our hope has been that directly accessing the immune system under the tongue, in that way, perhaps we can use a lot smaller doses. And then having smaller doses, we hope would be a lot safer. So far, at least for peanut, we've had now 3 different studies that seem to show that, hey, it can work. It gets pretty high threshold. So if we have someone who might be otherwise allergic to like even as a third of a peanut kernel, a tiny amount, after the treatment, we've got a lot of these folks eating 5, 6, 7, even 10 to 15 peanuts worth. So really able to sort of 10 to 20 times more than what it took previously. Again, is it a cure? At this point, it doesn't look like it, but it does seem like it's able to provide a big level of protection. But what has been really nice when it comes to this is that it seems like the safety has been really good. Mouth itch is something that comes with this, but thankfully the severe allergic reactions, anaphylaxis, things that might need your EpiPen seem to be very uncommon with this. And so this could be sort of that nice in between for folks where, again, they do see a reason to do something to treat, but again, I think the work that it takes and the risk that comes with oral may be a little bit much for them. And the hope would be sublingual could be an option. And then one that's still in development and trying to get to the FDA's is epicutaneous immunotherapy. I don't talk too much about it with my family just because it's not quite out there yet, but I do like to still let them know that these are things that are coming. And the idea that you could use a medicine patch, just essentially put on a sticker and then go about your day. Go play your sports, go to school, take a nap, whatever you need to do. I mean, that really could be amazing for so many families that are out there. And, will it get you to the point of eating peanut butter sandwiches? We don't know. Probably for the majority, no. But for families where that's not as important and more just something that they know will give them sort of that buffer against small accidental ingestions, at the same time, not creating an additional burden to their lives, that could fit the bill there too. So, I think in immunotherapy, there's been so much excitement there. And then, I hinted at before, but the biologics, omalizumab, just got approved last year. And, I think that is absolutely set up to be a game changer and has already started to look that way. And so many of the patients that I see in clinic are allergic to more than one food. And so, if I get that patient who comes in that is allergic to peanut, milk, and egg, I'll have the conversation about oral and sublingual, but really quickly we get to omalizumab because the idea that you could use one medicine to protect against multiple food allergies at once, oh my goodness, that's, something that's so important to talk about. And then we also know it's been out there, 20 years now for asthma and for hives. And so we know it can help with other allergic diseases. So multiple food allergies and asthma, like this one just seems like an automatic. We need to have this conversation. Now, is it for everybody? No. Omalizumab in itself is an injection. And we kind of talked about with the EpiPen, not everybody likes injections. We know it's not going to be a cure. It's going to work really well when you're on it, but it won't be a cure. And so there are going to be some families where this makes a ton of sense. There are going to be other families where it doesn't, and that's okay. Again, we come back to the idea that there are choices that are out there. And, maybe it's the kid who's about to start kindergarten for the first time, eating in a cafeteria with a lot of other kids, sharing food when they're not supposed to. That might be a situation where, hey, something like this might make sense. Or what I've seen in my clinic is some of the high school kids getting ready to go off to college and, oh my goodness, live on their own and cook and shared kitchen. And what is that going to be like? And, rightfully being somewhat anxious. And so could these be treatments that can help, again, just provide that buffer against the, unknown? And once they figure things out, maybe they stay on it, maybe they don't, but that's okay too. And so it is long conversations now, but I'm excited to have them because we weren't able to have these conversations five,
Yeah.
10 years ago.
Yeah, exactly. So, Edwin, you mentioned that you are a food allergy dad. So, as you've thought about managing food allergies as your kids are growing and launching into the world, what are some, you wear many hats. What are some considerations you bring in to your daily life about managing food allergies across the ages?
Yeah, I mean, thanks for asking. I mean, I think it's just been fascinating because, of course, I treated in the clinic as an allergist, been doing research in it, but also sort of as a parent and trying to sort of have all the different perspectives out there because I think it's important. I think sometimes we kind of live in our little research bubble and have an idea of what we think food allergy might be, but to really sort of live it on the parent side, I think hopefully gives me a perspective as well. Um, and so within our own actually family, it really comes back to what I was mentioning before towards omalizumab. I think that stages of life really make a difference. So I don't know that there's a treatment that you just sort of turn it on and that's it. I really think that as the kids go through the different stages, then I think that you kind of think back of how is food allergy affecting my child and our family, and then is this something that a treatment might be helpful? And so one of the earliest stages was going to be just going off to school or going off to daycare. And so when my son, who has peanut allergy, was first going to daycare, this was definitely a consideration, and OIT was just starting to come out. At that stage, for our personal family, really the idea was more that we're fortunate to have a peanut-free daycare in our home. We felt very confident when it came to peanut allergy, and so in our situation, we felt like, well, I think the risk that comes with avoidance was very low. And OIT was still sort of being understood and studied. And so it wasn't quite right for us at that time. I'm very careful to say it that way, though, because again, I think every situation, every family is affected differently by food allergy. And so I'm careful when I talk to my families out there that, my experience is not necessarily your experience, but I do want to share our experience.
And I think you're exactly right. I say that to my patients all the time. You know, it's got to be the right time, the right situation. And
Right.
sometimes that moment is not now, right? But it can be later and can be revisited. Now I understand like what the reasons behind why you're so amazing. You really do have an amazing perspective. Your patients are lucky to have you and your expertise, personal and research based. Because I think our food allergy families really go through a lot in the day to day because you're right. It's such a cultural thing surrounding us, all around us, and we can't control every minute of the day for our loved ones.
You're exactly right. And you know this, but food allergy is sort of an invisible disease, right? Thankfully, our kids out there are not having allergic reactions, every day. But that doesn't mean food allergy doesn't affect us on a daily basis, whether it's the choices we make in what to eat, where to eat, schools we go to, whatever it might be. I think there are a lot of different ways that food allergy can affect us. So I do think it's so important to try to understand where is the family at that moment, or in our case, where were we at the moment?
Yeah.
And then figuring out what those needs are and if it fits. And I think an important point I try to make to families now is that choosing not to treat is not a bad thing either. It just may not be the right time or the right treatment, and that's perfectly fine. And not to sort of feel like you're letting down your kid or anything because you're not. And the right treatment may not be there right now. But that's the other thing is we're doing, you and I, we're involved in so much research and we know that there's a lot more that's coming. And there's going to be different treatments, hopefully longer lasting treatments that are coming as well. So maybe one of the stuff that's out there now is not the right thing, and that's okay as well.
So, Dr. Kim, You are the leading expert on sublingual immunotherapy. You've done your name is associated with all of the publications, most of the publications on sublingual immunotherapy. Can you tell us what it means, what's involved, and how young, how old a patient do you have to be able to be considered for sublingual immunotherapy?
Yeah, of course. I do love sublingual immunotherapy. And I think that one of the first things I would say is the concept of it is maybe fairly new to food allergy, but not necessarily new to allergy. And I think that's one important piece of this is that we've been using sublingual immunotherapy for seasonal allergies for many, many years. And so I think that upfront gives us some confidence that, hey, this is something that we think can work and should work. We've also sort of seen the safety of sublingual immunotherapy when it comes to seasonal allergies, at least in comparison to the classic allergy shots, where allergic reactions can happen. And so, thankfully, in the setting of seasonal allergies, we've seen that it can be effective and then actually really safe. And so then we really kind of fast forward over to the world of food allergy, and we want to prove we know food allergy and seasonal allergies aren't the same. The chances of anaphylaxis are going to be, of course, higher with food. So we want to prove it. And so the way we've initially studied, just to kind of prove the point, is we've used the food, in this case, peanut, in a liquid extract form. So basically, at the company level, they're able to pull out the protein from the food itself and then dilute it in something called glycerin. Then we're actually able to use that in liquid form using a small dropper and put a set number of drops underneath the patient's tongue, in this case, kids that we were doing clinical trials with. They hold that liquid under their tongue for a couple of minutes, and then in our case, we just had them swallow. There's some research protocols or studies where they might hold it under the tongue and then spit it out. But in our case, we just thought it's nice and simple and a super small dose. So our studies have looked at 2 milligrams and 4 milligrams of peanut. And just to sort of give you a sense, one peanut kernel, so one lobe of a two lobe peanut is about maybe 300 milligrams. So when we're talking about 2 milligrams or 4 milligrams, I mean, again, it's a tiny, tiny, tiny amount of peanut.
Peanut protein,
Peanut protein,
right?
yes. So our thought is there, even if you swallowed it again, it's such a small amount that we would anticipate that should be safe. And then the idea there is, like the oral, to continue that sort of process on a daily basis, you're essentially trying to retrain the immune system, teach the immune system that this food is not deadly, and then help it build up essentially a tolerance. And so, like the oral, then the process is you do that on a daily basis for a couple of weeks, bump up the dose a little bit more, 2 weeks, bump it up and follow them until we get to sort of our treatment dose, or the term we use is maintenance dose. And then at that point, we know that there's already a benefit that's there, but keeping on that treatment, really trying to make those changes to the immune system long lasting. In a perfect world, we want to get it to the point where you don't have to necessarily be on that treatment and some level of protection is still going to be there.
Yeah, that is the ideal treatment that we're looking for, is that, that at some point we maybe don't need a treatment. But for sublingual immunotherapy in the studies that you've led, how long a treatment period are we talking about?
Yeah, so our very first study, where again, just trying to prove can this even work, we looked at actually just 1 year and wanted to prove whether compared against someone taking the placebo. So basically the liquid without the peanut in there. And we did see that, yeah, it's able to increase how much peanut it takes before an allergic reaction happens. After that, then really in our minds, we were thinking, okay, classically, when we're thinking about allergy treatments like allergy shots for pollen allergy, we normally treat for 3, 4, 5 years to get the lasting benefit. So that initial group, we actually treated them for 5 years. And then we followed it up with 2 more studies, one for 4 years and one for 3 years, looking for this long lasting benefit. Do you need to stay on it that long to get a benefit? No. Again, what we have seen from the early studies as well as from our lab findings is that we're thinking that patients are already protected to an extent, even after 6 to 12 months. But we do think that by staying on longer, you continue to increase that benefit. And then you have a much higher chance, hopefully, of getting a lasting benefit when you're done. You previously had mentioned about sort of age, and that this is a place where the age kind of fits in. So we do feel good that this is a treatment that could work at any age from an efficacy point of view, from a safety point of view. But we have seen, similar to other studies, that it does seem if you can get in there early, shortly after being diagnosed with the food allergy, it does seem like the benefit could be stronger and maybe even possibly longer lasting. This is definitely something that we're interested as well. And so we've studied all the way down to age 1. And as it turns out, the 1 to 4-year-old kids did really, really well. Compared to like the older kids that are more elementary school, did they benefit? Absolutely. The elementary school kids, we had them eating 7, 8 peanuts and seeming to do really well at that point. But when you think about the 1 to 4-year-olds, those kids were maybe eating 10 to 15 peanuts. Just an example that I think it can absolutely work across the ages. But if you can get in there early, I think we might be able to even get a slightly better benefit and maybe longer lasting.
Great. And so this is drops underneath the tongue. What about like a 1-year-old? Do you think it's just as effective to be in the cheek or like anywhere in the mouth? Does it have to be underneath the tongue?
Yeah, so this is absolutely the number one, number two, and number three question we get is how in the world do you get a 1-year-old to hold this stuff underneath their tongue? And I will say we have amazing research coordinators who are really good at what they do, but they're not going home with the families. And so, yeah, I think as soon as they go home, I'm sure it's hard. And again, we're very excited and fortunate that the results were still super duper promising, even if they weren't perfectly able to hold it underneath their tongue. But it does sort of go to the question that you mentioned of, well, could it be in other places in the mouth? And there is some research that has been done in the past that shows that those same immune cells that we think are important under the tongue are in the cheeks and other parts of the mouth as well. And so even in the cases where they don't hold it well there, if it's sort of coating the inside of their mouth, one of our thoughts is it possibly, we hope, continuing to absorb throughout in the cheeks, under the tongue, all over the place in the mouth, and that way still getting the benefit that we're looking for. But this is a place where I will mention that we are also looking into a dissolving tablet version of this. So as opposed to the liquid that might be harder to hold under the tongue, the idea of this tablet is that it's a very small tablet that dissolves within a few seconds. The nice part about this is it sticks. Basically, you stick it under the tongue and it sticks there. It doesn't move around and then it absorbs right there. And so this would be nice. We're studying it right now to really tell us how important is it to stay underneath the tongue and absorb there. My suspicion is it should be the same, if not better than what we have seen before. So it would be really exciting to see what those results are.
Yeah, that's great. And is it similar to the tablets that are already available for grass or for dust mite? Similar concept for peanut.
Exactly. Yeah. So again, another thing that makes us feel good about this is, like you said, these same type of tablets have been used for those pollen allergies, and again, shown that it can be safe and be effective. So we feel really good, but we need to prove it because we know food allergy is not quite the same. But we are very excited and optimistic that this will also be something that could be one more option out there for families.
Great. And then thinking about the amount that is used in sublingual immunotherapy, we've seen a publication about oral mucosal immunotherapy, kind of like a toothpaste version with peanut in it. There are studies out there looking at low dose oral immunotherapy, so not the traditional amounts that we build up to, but much smaller amounts. What do you think about dose and route or methods of immunotherapy? You've already mentioned also the patch, which is very low doses through the skin.
Yeah. So the way I would answer that is kind of first getting back to that super exciting part to me that there are choices that are out there. And we're continuing to think about choices. And I think that comes back to sort of your question about dose. And so when it comes to sort of the low dose oral immunotherapy, I feel really good that it's going to work. And we see it from some of these early studies that, yeah, it can work. Is it going to get us to the same level of threshold or protection that a super high dose of OIT can get to? Maybe not. But is it going to be easier to do and safer? Probably. And so again, for some families where the safety and the burden of doing it is more important, that could be an awesome option. There may be some families that for one reason or another that they just need that maximum threshold, and we have that option as well. And so I think the lower dose oral immunotherapy is going to be something really important and exciting for us to study, whether in research trials or in clinic. And then you mentioned about sort of this toothpaste. And so kind of taking our sublingual concept. And like I mentioned up front, really, in my mind, what we have tried to do is prove that this can work and understand sort of how it works. But we can't stop there. We feel good about what we've seen, but we need to find a way to make it better. And so one of the ways that might make it better is taking advantage of all the immune cells that are throughout the mouth, not just underneath the tongue. And so this sort of toothpaste that would coat the whole inside of the mouth, that could be it. So it'd be great to see sort of, do we get that benefit, the improved benefit that we would hope to see that comes with that? Now, another thing that has come out as well is we're using this sort of commercial extract, this protein that we're getting specifically made at a company. But some folks have wondered, well, could we do the same thing with food? And we don't know. I mean, it would be a lot easier, I think, if we could take, say, peanut flour or milk flour and dilute that and use that. But I do think it's important for us to sort of not jump the gun on this because we are still talking about food as proteins that are being absorbed in the mouth, under the tongue. So it may be the same, but it may not be. So I do think it's important. It's an important question for us to have, but I do think we need to try to understand it before we sort of get it out there and sort of see what happens. Because again, at the end of the day, these are still patients. These are still our kids out there. So we want to make sure that we are doing things right and keeping them safe.
So, Dr. Kim, we have a few questions from the audience, and so I'll just go through them. Is one spray of nasal epinephrine the same as one injection of epinephrine?
Yeah, great question. And absolutely. I think I try to tell my patients to think of it exactly the way they would think of an EpiPen injection. So one spray, if it doesn't work within 10 minutes or so, get ready with that second spray, exactly like you would with an EpiPen.
Great. Another question from the audience talking about allergic reactions and the symptoms that occur after an exposure to the food that they're allergic to. Is there a definite sequence of symptoms that typically happens?
Yeah, great question. And I should have hit on that earlier. A lot of our patients ask us, oh my goodness, if I got one hive, does that mean next I'm going to be throwing up and then next I'm not able to breathe? Thankfully, we know the majority of reactions people will have will be relatively mild, but that doesn't mean that we don't want to be ready. Each reaction is going to be a different reaction. So you could have hives a couple of times, another time you could have vomiting. But we do know that all of those any combination of those are possible. So we always want our families to be ready, but think about each reaction sort of as its own reaction and being ready to treat it as appropriately.
Great. And a follow-up question to that, why do reactions differ? What are these things that we hear about cofactors for an allergic reaction?
Yeah, I think I'll start answering that by, some of my patients ask me, oh my goodness, the last reaction was kind of mild. Does that mean the next one will get worse? And the one after that will get worse? And thankfully, that's not been the case from what we've seen, is that again, each reaction seems to be sort of be its own, and the majority of these will be mild. But the cofactors that you brought up, so we also know that there are certain situations or things that can actually allow for a bigger reaction to happen. One of those that we have seen, especially around sort of thinking about oral immunotherapy treatment, has been exercising. And so someone's sort of threshold might be maybe a couple of peanuts is what it takes for them to have allergic symptoms or an allergic reaction. But if they have peanut at the same time as playing soccer or running around, whatever, around the track or something like that, they may have symptoms to a much, much lower dose. Similar, if someone is sick, if they've got the flu or COVID and they got a fever, it seems like it decreases their threshold and allows more allergic reactions to happen. And so it's just one of those things that we've learned over time, and we're trying to, again, coach our patients, so coach our families to sort of be ready for that and be aware. And again, this comes back to it's always going to be important to remember still allergic, protected, but still allergic, and you want to have that epinephrine available just in case.
Great. I mean, I think that's an excellent point that even if you're on therapy for your food allergies, you still need to be prepared to manage allergic reactions. One more question, Dr. Kim. What do you advise patients about labeling that says may contain foods or the precautionary allergen labeling that we see on store items?
Thanks for that question. I mean, it's something we talk about in clinic pretty much on a daily basis. And it's just so frustrating because labels are supposed to be helpful. Fortunately, what we call these precautionary labels, the may contains and traces, I think have made it more confusing for folks. So when I talk to my families, what I tell them is these are voluntary labels. And the majority of the time, this is probably just the companies just being careful and protecting themselves. And the amount of actual food allergen in there is probably minuscule or even zero. But at the same time, I do tell my families I can't promise them that there's no exposure that happens there. I know that the vast majority of my families would be perfectly safe if they ate those foods. And so I leave it up to the families. And some families say, well, if there's a chance of a reaction, that's just not for me, and they avoid it, and that's okay. There's other families who say, okay, understanding that it's going to be a very, very, very small amount and uncommon for a reaction, that's good for them, and they're able to eat that. And so within our own household, we've been comfortable with that. We're always ready and aware, looking for allergic reactions, but we are understanding that these precautionary labels are not going to have much exposure there. Our family generally does eat foods that have those labels, and we've been okay with it for now.
Thank you so much for that very nuanced perspective. It's not easy, but I think having those conversations with our families and educating them to help them make the decisions that are right for them is really the most important part. Thank you so much, Dr. Kim, for joining us today. We are so grateful that you are so enthusiastic, not just about what's already been done, but about things that are on the horizon. And the field is very lucky to have you as a researcher, as an advocate, as an educator. Thank you so much for joining us on our webinar today.
Yeah, I'm just so excited to be here. And yeah, I mean, I love what I do, and I'm really thinking the future is bright for food allergy families out there.